I'm going to share with you our experience with the CAR-T therapy. CAR-T stands for chimeric antigen receptor T-cell therapy. It is a kind of immunotherapy. Some people also call this a gene therapy. Immunotherapy is not new. We have been using monoclonal antibody for treating cancer. We have also more recently the PD-L1 inhibitions for treating kidney cancers and also lung cancers. Indeed, allogeneic bone marrow transplantation is also a form of immunotherapy because the donor cells, the donor T cells, is a very potent anti-cancer treatment. Next slide, please. For CAR-T therapy, the first step is to harvest the T lymphocytes from the patients. And then we send it to the laboratory. With the modern technology, we can now introduce a gene that encodes a specific receptor to direct the T cells against the cancer cells. This was not possible in the past because we didn't have the technology, but now we can use the retrovirus to manufacture CAR-T cells. After making the CAR-T cells, the cells will be grown in the laboratory, in the clinical GMP laboratory, to expand the number of cells. These cells are then reinfused back to the patients. Before that, we actually have to deplete the lymphocytes in the patients before the reinfusion. There are current indications, however, with restrictions, to use these cells. For example, relapsed acute lymphoblastic leukemia, relapsed high-grade B-cell lymphoma, especially the diffuse large B-cell lymphoma, after 2 lines of treatment. Other new indications include mantle cell lymphoma, plasma cell myeloma, and maybe in the very near future, follicular lymphoma. There are different kinds of CAR-T cells. What are they? And these cells contain a chimeric receptor, which is a synthetic protein expressed on the surface of the patient's T lymphocytes. These receptors can recognize a specific protein on the cancer cells by design. And for B cells cancers, we target the CD19 proteins sitting on the malignant B cells. Of course, we can use other targets for other malignancies, but this is the field, this is the development for the future. Not only the receptor is important, there are also other parts inside the T cells which are also important. They are called the intracellular domains. These domains ensure that the intracellular signaling is effective to activate the effective functions of the CAR-T cells. For the first generation cells, they use the CD3 zeta chain of the T cell receptor. However, it doesn't support very well the T cell expansion after reinfusions. Then we now have the second and third generations of the intracellular domains, which I won't go into the details. Currently, only one of the many CAR-T cells products are available in Hong Kong and at Hong Kong Sanatorium and Hospital. The one that we have is called the Chimera, and the CAR-T cells are produced by the Novartis laboratory. This is the only one commercially available in Hong Kong at the moment. This is a CD19 targeted cells, and also they have this murine single chain antibody fragments that recognize the CD19 and fuse into the intracellular signaling domains that are mentioned before. And these intracellular domain is very critical, as I've said, as an activation domain and also as a co-stimulatory domain. And then we also have a hinge on the T cell membranes to bridge the two. What we have done is that we harvest the T cells from the patients in our hospital and then ship it to the United States laboratory. and the cells were processed in the United States laboratory. And what we have seen in the literature is that these cells are effective in treating relapsed diffuse large B-cell lymphomas. The overall response rate is slightly over 50%, and the complete response rate is 40%. You can see that for those patients who are responding very well, actually the complete responders, actually they do have a good survival. And for those with partial response, of course, many of them will relapse very soon. The CAR T cells are not without side effects. There are a few important side effects that we have to be cautious of. The first one is the cytokine release syndrome. It occurs usually quite shortly after the T cell reinfusions. The symptoms include fever, hypotension, and organ failures. The treatment is effective using anti-IL-6 therapy, steroid, and also good supportive therapy is important. The second adverse effects is neurological toxicity. Often it occurs together with the cytokine release syndrome, but not always. The symptoms consist of headache, confusions, dysmetria, which means that the patients cannot write, ataxia, dysphagia, and tremors. In severe cases, there may be seizures, coma, or even respiratory failure. Fortunately, these adverse reactions are usually quite reversible, so that the mortality is not high. The late side effects of these CAR T treatments would include cytopenia, B-cell aplasia, and hypogammaglobulinemia, which means that the patients are at risk of infections for quite a period of time after the treatment. Although the treatment with CAR T cells are effective, it is not without morbidity. So we have to be very careful, and this treatment is usually only available in specialized accredited centers, and our hospital is one of them. When we use these cells, we have to select the right patients. It is important to have good disease control before the T cell harvest. And also, it takes a few weeks to produce these CAR T cells. Therefore, it is important to keep the patients in good shape before we reinfuse them with the CAR T cells. So some patients may need bridging therapy before we give them back the CAR T cells. And good organ function is, of course, important so that they can stand the treatment. Unfortunately, the important part in our logistic is the financial. It is quite costly, and also the patients requires quite prolonged hospitalizations. In the more experienced centers, patients can be discharged early, but these patients has to be lived near the hospital. So in case there's a reactions or side effects, they can come back to the hospital immediately. In our experience, in negotiating with the insurance can be a very tedious process. Therefore, we have to plan ahead. If we have a patient that requires this treatment and there's an insurance cover, then we have to start the negotiation as early as possible. I think CAR T therapy has given us another good treatment for patients, especially relapsed lymphoma. However, the treatment indications is still limited at the moment, and we hope that we can expand the indications. Whether earlier use is more useful, or whether it can be used in other kinds of malignancies with other targets, with CAR T cells with other targets. And also, great interest is to use CAR T cells to treat other solid tumors as well, other than just blood cancers. Also, there are experiments using sequential CAR T cell therapy targeting more than one antigen. Hopefully, it can be more effective and prevent relapses. Also, new generations of CAR T cells, which can persist for a longer time in vivo, is very important so that the efficacy can be improved. And Dr. Ma will tell you more about this later on. I think the future probably lies in the allogeneic CAR T cell, which is available off the shelf. It is kind of modified allogeneic cells, which can overcome the HLA barriers, which means that we no longer need to harvest the autologous T cells, therefore avoiding time delay. It is just available in the freezers, and we can just give it to the patient when needed.